Hello, welcome to another episode of the World Stroke Academy podcast series on the role of factor 11A inhibition for stroke prevention. Today we're going to move to discuss a little bit how the evidence can be translated to clinical practice and implementation. As you know, my name is Octavio Pontes. I'm a neurologist and professor of neurology at Ribeirão Preto Medical School, University of São Paulo, Brazil. Also the editor-in-chief of the World Stroke Academy. And today it's my great pleasure to have with me today Professor Valeria Caso. Professor Valeria Caso is Chief of Neurology and the Stroke Service at Sorono Hospital in Italy. And she's a leading expert in the field of stroke prevention. Valeria, thank you so much for joining us.
Thank you for inviting me.
Valeria, could you please tell us a little bit about in which populations do you understand that the results of the OCEANIC-Stroke trial would apply, would benefit, what population would benefit the most of this kind of strategy?
So looking at the data, it's quite easy to answer because all patient who has a stroke without atrial fibrillation can benefit and have shown to have benefit from the treatment. So as neurologists, we like to distinguish, and I think it was good that we create all this distinction, the classification in small vessel, large vessel disease, cryptogenic, ESUS, non-ESUS, and other causes. But if you look at the data of the results, all the 75% of patients who are not cardiobolic due to atrial fibrillation benefit clearly from the add-on treatment of factor 11. So we know that there's an unmet need. 12% of patients will have a recurrence after 1 year. 25%, 1 in 4 will have a recurrence. So we did never, as stroke neurologists, we didn't face this really because we were focused on acute treatment. We tried to do our best to improve acute treatment, thrombolysis, thrombectomy, be fast as possible. But we realized that unfortunately some of our patients will return. And this, we have to put them on the safe side.
Mm-hmm. Yes, the fact that the results show incredible safety, I think it's reassuring for us, right? You comment also on the fact that different from the previous approach, we were used to select patients for, TIA and minor stroke for double antiplatelet lesion, for instance, for 21 days or 90 days. And then there were the prevention trials that usually were started several months after the stroke, and in this case, the OCEANIC-Stroke recruited patients within 72 hours, and the patients were on medication for years, right? So do you feel like this difference would also change the way we think about stroke prevention and starting the medication as soon as possible in the ED?
No, this is an excellent point because we, as neurologists, doing our diagnostic workup, so already caring about these patients, in the same moment we start to put them on the safe side. So we put on add-on treatment, which we know it's effective, which we know is safe. In the meantime, we can continue to do all our examination because we have to do the high-level work because it's easy to say it's 70% of strokes are not cardiobolic, but we need to look for the other causes. But we start a treatment and then continue to do all our diagnostic workup.
So very reassuring for us. Right?
Yes.
So in terms of implementation, Valeria, now, what do you foresee as possible barriers to implementation of this new strategy in the stroke field and I would say also in developing countries?
Yeah, every kind of new drug, the first thing that comes to your mind is the pricing.
Okay.
And clearly, as we know that the benefit is high, this is something that we need to take into account because where is the highest burden? Often there are the poorest country. And we know that the greatest burden is in low and middle income countries. And we cannot permit that these patients are untreated because also for the fact that they're working age. So if you lose the capacity to work, you lose the capacity to maintain yourself. You don't have the social system, you have the families behind. So it's so important for us to work on this and say the return of investment of a drug that may cost more than aspirin, which is clearly cost more than aspirin, and also clopidogrel and ticagrelor, because they're almost generic now.
Right.
But to say, okay, there is an initial cost, but the return of investment is so high for patients that we need to push for it, that they enter in this pathway for being treated.
That's a very good point, and I would say that it's reassuring for us the fact that several countries, developing countries, participated in the trial. So this, we have patients from these countries in the trial that may help us to, implement this kind of strategy and to engage, governments to understand that this kind of intervention is important also in developing countries, right?
Yeah. You think about the world, how the world was some years ago. So the access to knowledge was not so easy. Now we have, for example, Woodstock Academy. So the access to knowledge and to innovation has dramatically changed. When I was young, I had to go to the conference and then wait for months that the paper comes out and so on. Now you have the possibility to go to see webinars, to look at the website. So it's also, when you know that there's something better and good for you, you will ask for it. And knowledge is the best defeat against not being treated.
That's very helpful. All right. Thank you so much, Valeria.
Thank you.
All right. See you.